heute Alkoholmissbrauch im Rahmen Lebertransplantation. Ich werde über Alkohol-Lebererkrankung, Transplantation und Alkoholmissbrauch sprechen. Ich werde auch jetzt Englisch wechseln und here we have my outline for the presentation. We're going to talk about overall alcohol-related liver disease, not alcoholic-related liver disease. This is a big change in terms of stigma that we should always in our reports, and we're speaking about this disease, change the term to alcohol-related and not alcoholic. We're going to talk about ALD in the transplant setting and how do we manage alcohol use disorder, not alcoholism, in the OLT setting. First and foremost, why am I here today? Well, because it is the major cause of liver disease in Europe, where we live. And honestly, most importantly, this is a highly harmful consumption and a highly preventable disease. If we look at this graph here, if you look on the left side of the graph, we see that the relative burden in chronic liver disease of ALD is rising, as is also metabolic liver disease. And the relative burden of cirrhosis is clearly rising for ALD. So this is something we really need to tackle as doctors, digestive disease doctors, doctors who treat patients. What is the natural course of ALD? Well, quite honestly, when we usually see these graphics, we have a stage liver steatosis, steatohepatitis, and liver cirrhosis and complications. What's a little bit different about alcohol-related liver disease in comparison with other liver diseases is that we pretty much divided in a subclinical disease, and that ranges from a simple steatosis to a compensated cirrhosis. And then we have another stage, called the advanced liver disease. And here we have patients that have alcohol-related hepatitis, patients with acute on chronic liver failure, and patients with decompensated cirrhosis. So really, it's the only disease where we would consider a compensated cirrhosis a subclinical disease, or let's say early disease. And that's because most of the patients, when we're going to receive them, are very much in a very advanced stage. This study is a wonderful study. I cited in all my presentations. Very simple study that just basically showed us that when we look on this graphic on the right left-hand corner, what we see is that ALD, in comparison with other diseases, viral or NAFLD, and we see that the bar here is dark blue, is advanced liver disease. This is when the patients are referred to us, most of them are already a decompensated state in a very advanced. And when we look overall here on the bottom part of the slide, when we look at all different areas, when we look at the burden of more advanced disease, ALD alone or ALD as a double etiology is always related with a more advanced disease. And here, what we really need is to develop early detection programs for patients who have alcohol use disorder and have harmful drinking. We have to use more collaborations between alcohol clinics, primary care, and liver centers like ours. And we need to also do a universal screening for alcohol misuse, particularly something that's underdone in acute medical admission. We obviously need better designed quality clinical trials in this setting. And we really need to create better pathways from primary to tertiary care. And so here, this is dating back quite many years ago, over 30 years ago, this paper from Dr. Tom Starzl, who showed his series or his experience of OLT for patients with alcohol-related liver cirrhosis. And what he reported is that not so bad, a 1-year survival of 73% and a 3-year survival of about 68%. But here, what I'd like to highlight is here on the right side of the graph, right side of the slide. The use of OLT to treat patients with LINEX, as it was called, LINEX cirrhosis, has been criticized by healthcare personnel or even prohibited by agencies responsible for healthcare funding. And that's what makes this particular etiology a very special one in the setting of liver transplantation, because it carries a lot of stigma, not only from society, but also within healthcare personnel. Nonetheless, what do we see in terms of trends, and this is taken out of the European Liver Transplant Registry, is that alcohol is the #1 referral for liver transplantation. That continues to be the same. We see that hepatitis C has decreased progressively and quite dramatically in the past 10 years. Alcohol remains high with some peaks and high points. Some data showed that after the COVID pandemic, there was a clear rise in and referrals. And here, when we look at the proportion of non-HCC listings, so we usually separate this non-HCC, HCC, we see in this graph in purple, we see that ALD listing continues to rise over time. In addition, we also see, of course, metabolic associated liver disease as a rising cause for liver transplant listing. What's also a rising trend is listing patients for severe alcohol-related hepatitis. I think we all have experience in our clinic. These are patients that come severely ill, jaundice with coagulopathy, many times with associated portal hypertension-related complications, such as ascites, severely malnourished. And these patients with severe alcohol-related hepatitis, generally what we treat them is with steroid therapy. When indicated, that usually means when we have patients that have a MEL score between at least 20 to 50, the best window is between MEL 25 and 40. We no longer use MADRI as our decision to start steroids nowadays. And what we see is that in the past years, here we have in dark black, the bottom part of this graph, the wait listing, depending on the last, let's say, 10 years, we see that alcohol-related hepatitis, there has been an increase, a steady increase. When we look at other ALD, meaning ALD cirrhosis, or not in the setting of a severe alcohol-related hepatitis, we also see that other ALD-related diseases are increasing, while others have pretty much stagnated. And here, also from the European Liver Transplant Registry, what about survival? Are the outcomes different for ALD patients in comparison to other etiologies? Well, here we see ALD is in this green line, and we see it's in the middle of the pack. It's pretty much the same and similar to other ones. There are other diseases that have better outcomes, such as Hep B or autoimmune liver disease, but in fact, it's par and par with metabolic liver disease, the other growing cause of referral. And when we look at 1 and 5 year survival for patients with ALD, we see that it's quite good, 87% and 75%. When we look at statistics on donation transplantation here from the United States, we see that patient survival among patients who received deceased donor livers, here from a short period from 2013 to 2015, we see really that there is no difference in terms of survival in most of the etiologies. Now, we've all heard the 6-month rule. And I have, let's say, a pet hatred for this rule, and mostly because it's not evidence-based. So this 6-month rule arose out of a survey that was taken from around 70 OLT programs in the US, where they asked experts, so let's say this is evidence-based, they asked experts, what are the factors that influence your decision to list a patient with alcohol-related liver disease? And let's say overwhelmingly, what most of the experts felt were more relevant factors besides social and family support was the duration of abstinence. And based on this, what we know is that even until very recently, 85% of programs, at least in the United States, require a 6-month abstinence before transplantation. And another point I'd like to say is here I have a question mark in terms of timeline. So for about 30 years, this has been the rule that has been used in Europe and the United States and still in many centers around the world. And let's say the thought process behind the 6-month rule makes some sense. First of all of us who follow patients with liver disease know that sometimes after even 3 months, with proper nutrition, alcohol abstinence, patients can really recompensate. So they can, their ascites can resolve, the jaundice can resolve, and encephalopathy can resolve. And so this, in terms of giving patients time to see if they're improved, was the thought process behind it, one of them. The other one is it would give time to refer patients to addiction specialists. And here I highlighted and read something that's I think is particular to the United States healthcare system is our insurance requirements. And here I think also sort of moralistic impact of society about this rule. But we see more and more that this is not evidence-based and should really shy away from using this as a general rule. And here, what really was a huge game changer in alcohol-related liver disease and liver transplantation is this landmark study from the group from Franco-Belgian liver transplant centers led by Philippe Mathurin from Lille. This was published over 10 years ago, and all of us in the liver world saw how this rocked a bit concepts in liver disease and particularly liver transplantation. This included 7 centers. The criteria was a MADRI at the time, over 32, and a very supportive family environment. The patients had to have a first decompensation, meaning these were not patients that had multiple decompensations or patients who knew they had liver disease. And they compared 26 patients with 26 match controlled who did not receive an early liver transplantation, meaning these patients did not wait 6 months to receive their liver. And this is quite striking Kaplan-Meier curve survival, where we can see on the upper part of the graph, patients in this dark gray line, patients undergoing liver transplantation had a 2-year survival around 70%. Patients who did not receive had a survival around 25%. So it's a striking difference. What did this show us? It shows that basically patients do survive it, and if they don't, many of them do die. When they did a deeper analysis and they looked and to see what about patients who actually responded to steroids and didn't need it and improved, well, actually these had about an 85% 6-month survival compared to around a 78%. It was not very different. Well, if we fast forward 7 years later, the Americans joined what was already established here in Europe. They published the Accelerate alcohol-related hepatitis study. Here, 12 centers in 8 regions in the United States. And what do they show? Well, if you look here on the right side, what they showed is not very different from what the Europeans showed, is that 1 year actually was a little bit higher here for the Americans, 94% post-OLT outcomes, and 3 years, 84%, meaning these patients survive over time. When they looked at sustained alcohol use after transplant, it varied at 1 year, about 10% and 17%. And I want to say sustained alcohol use does not mean that's necessarily harmful drinking, but it is drinking that has maintained at least for 3 months. So we're not talking about a short relapse or slip, we're talking about sustained alcohol. Here we have a sort of summary of what are the studies on early OLT for severe alcohol-related hepatitis. The inclusion criteria are not very different. Most of them are non-response to steroids, a very good social background and support in the families, and no previous history of severe liver disease, nor any severe coexisting or psychiatric disorders. And what we can see across the board, 10 years ago and 1 year ago, what we see is the 1 year survival rate ranges from about 83% to 100% more recently. And when we look at another important outcome, which is the alcohol relapse rate, we see that this varies between 11% when we're looking at harmful amounts to about 12 or 13%. Okay, what about when we compare early OLT? That means we're not waiting those 6 months. Patients are very severe, they need to be transplanted as possible. And we compare them in terms of outcomes, so patient survival and allograft survival, with patients who have an ALD in a standard liver transplant setting. Well, I think these Kaplan-Meier curves are also very clear. There is no difference in terms of survival. When we look at the 1 year relapse-free survival, 80% versus 83%. And when we're looking at hazardous relapse-free survival, we're looking at around same values, 86% to 89%. Okay, so we have quite good data showing that these patients survive. They don't have very high percentages of harmful alcohol relapse. Have things changed in the meantime since that first survey that we saw? And the answer is yes. Thankfully, there has been a change in many transplant centers, particularly throughout Europe. And the questions are, regarding severe alcohol-related hepatitis, were there any changes to management since 2011? I remind you, this is the date of the landmark study from Philippe Mathurin, and the answer in most cases was yes. And when we look here, did you perform ALT in your center before in this setting, 2011? The answer in the majority of cases was no. So clearly there have been changes. We also see this in our own center. What happens to the patients that are declined early OLT? We know that in terms of 6 months survival, about only 40% will survive in patients with severe alcohol-related hepatitis. that are not transplanted. And this is a retrospective study done within the setting of this Accelerate American-based trial. And here what we saw is that 145 patients, among the 145 patients that were declined for early OLT in setting of a severe ALCAV, 56%, so the majority of the cases were declined for psychosocial reasons. When we looked at survival outcomes in this group of patients that were declined transplant, what we see is that the 90-day survival is around 60%. So after 90 days, about 40% of the patients died. Around 1 year survival is less than 50%. Interestingly, what we also saw is when we look at the probability 1 year of the patients recompensating, meaning the patients are no longer jaundiced, they no longer have ascites, they still have a cirrhosis, but they have recovered from the complications, it was quite low, so it was 10%. Among the patients that were declined, because what was observed was that there was an actual improvement, although they hadn't responded to steroids, there was a clinical improvement and it was decided to then not transplant them. But we saw that the 1 year probability here was quite good. It was about 30% of recompensation. And when we looked at a factor, for example, such as age, when we look at patients that are younger than 45 years, which is quite common in this patient population, we saw that there's quite high levels of recompensation in this. When we looked at the multivariate model assessing factors associated with death in this particular population that was denied or declined liver transplantation, we see that age is a major factor. Obviously, MELD score were determinant factors to predict mortality. Okay, so with great responsibility, also with great, let's say, changes come great responsibilities. We have an organ shortage, particularly here in Switzerland. This is a great problem. How can we choose the best patients? Well, here we have two factors to consider: psychological condition and the clinical condition. Regarding the psychological condition, we have two primary questions. How do we standardize the evaluation to make this most scientific possible to choose the patients? And how can we evaluate the risk to relapse? Well, and many times in these patients who have been out in the setting of a cirrhosis, they present with a syndrome called acute and chronic liver failure, which is more or less decompensated liver disease with organ failure associated. So this study was published over 6 years ago, and it showed when we apply treatment, OLT in this case, for patients with ACLF, here, the gross majority of the patients were patients who had alcohol-related liver disease. We see that they clearly survive much more, severely more, so 84% versus less than 10%, meaning these patients certainly survive even though they are severely ill. Here we're looking at more or less 1 year survival. When we look at differing degrees of ACLF, so grade 1, grade 2, grade 3, we see in this Kaplan-Meier curve, in fact, there's not a huge difference, perhaps a little bit lower for the ACLF grade 3 in comparison to patients with ACLF grade. How can we stratify utility based on pre-OT factors? Meaning, how do we select based on clinical factors who are the patients that we are going to decide to transplant, or we say, no, it's futile. If we transplant this patient, they're going to die, and there's no hope. So this is something that was published about 2 years ago. It's a sort of expert statement of some criteria one can use to consider postponing or really withdrawing a patient from liver transplantation. And among these, we're going to go step by step. We have, for example, patients that had severely frail patients, which is not uncommon in this population. Patients that have a clinical frailty scale above 7. These are patients where we should consider postponing or withdrawing. If patients present one of the following, meaning signs of a sepsis or severe infection, meaning persistent fever over 39 degrees, severe leukopenia, appropriate antimicrobial treatment of an SPP or a pneumonia, but less than 72 hours, or previous infection with Enterobacter, here we should consider postponing or withdrawing, according to expert opinion. In addition, if patients have lung failure, meaning if they have FiO2 ratio less than 150, or a noradrenaline use above 1 microgram per kilogram per minute, or a lactate level above 9, these are also criteria where we should consider postponing or withdrawing the patient. And importantly, and this is perhaps a bit of a subjective criteria, but if we see that we have a patient that's, for example, in intensive care, and they've been there for about 3 days, and the clinical situation is really not improving, although they're under noradrenaline support, vasopressor support, antibiotics. If after a few days we do not see a clear clinical course that's going in the right direction, on the contrary, it's going in a worse direction, this is another reason that one would consider postponing or withdrawing a patient from liver transplantation. What about, and here I won't have a lot of time to talk about it, but of course, another challenge that we have now as transplant doctors is the post-OLT recovery. These patients tend to spend many, many weeks on the wards before they're transplanted. Many of them are severely frail, malnourished, and require many times months of rehabilitation to recover. And probably the highest risk problem we have in this population group, which we see and currently have a couple of patients on the ward that reflect this, is that many of them develop post-immunosuppression, they develop severe infections, and something we have to keep a very close eye on. Now, referring to psychological conditions. Here we have the Stanford Integrated Psychosocial Assessment for Transplant, or CPAT. This is the psychosocial evaluation pre-transplant. What do we use here? Of course, this is based on evaluation from psychologists and psychiatrists, as we have in our center. What are the criteria that are looked at? Well, first, what is the patient's readiness? Or what do they know about the disease? Do they understand how severe the problem is? Do they acknowledge this? Are they willing to treat their disease? Are they compliant with medical issues? In terms of their social support, do they have one? How functional is it? And what kind of living conditions are these patients in? In terms of psychosocial stability and psychopathology, it's important here to know, do patients have personality disorders? Do patients have severe psychiatric disorders besides alcohol use disorder? And in terms of their lifestyle and the effect of substance abuse, how long has this been a problem for the patient? Is it really something that has continually recurred in their life? Do they have other illicit substance abuse? And in some cases also, do these patients have examples of criminality in the past? Here I'd like to take a really nice study done also by the Franco-Belgian group called the Quick Trend Study. And here I just, as a snapshot, what were the criteria that these centers in France and Belgium used to list their patients in the setting of a severe alcohol-related hepatitis? And here we have it more or less divided in 3 parts. 1, basic somatic medical conditions. Do the patients have severe comorbidities, as we would for any other patient? Do they have active cancer, lung, heart, brain disease? And here, scoring between yes and no. Is there a past medical history of liver decompensation within hospital stay? This, as you see, if the answer is no, the patients get many higher points, which is a favorable limit. Meaning it's not necessarily a criteria that we must follow, complete absence of previous, but it's something that should really weigh on our decision to list a patient or not. Part 2, we have a global assessment by an addiction specialist. Here, the addiction specialist evaluates if the patient has any severe psychiatric disease, psychosis, anorexia, or other issues. They evaluate the history of very harmful drunkenness, of self-harm, and actually externally directed aggression in these patients. Very important family support evaluation, and then a subjective evaluation based on the degree that the psychiatrist or the addiction specialist thinks of this patient's degree to adapt. And then we have our liver team. So here in the liver team, we have quite a few points. We have at least 12 points that are evaluated. We have the motivation of the patient, their adherence to the medical program. Is this patient dynamic? Meaning, do they want to die? Do they want to live? Do they want to live? Do they have future projects for their life? Then we have the criteria of family support. Are there relatives or friends that are there that provide good support? Are there alcohol problems within the actual relatives? Is there a harmful environment for the patient? And here we have a few questions that should be asked for the relatives. In sum, what we know is that based on this quick trans study, when the patients displayed a final score less than 200, the authors concluded that the patient should not be considered a candidate for liver transplantation. And if they presented a score above 220, at least in this study, they considered the patient to be a good candidate for early liver transplantation. What about drinking after liver transplantation? Well, as you can see in this graphic here on the left, it varies a lot. So we have people who have just slips. We have people who have non-harmful, very light alcohol relapse, patients who have frequent and binge, or patients who have frequent alcohol and extreme binge. And so here, if we look on the right side of the graphic, what we see in terms of probability of survival is that patients that have a pattern 1, meaning patients who are abstinent, that's in the solid black line here above, and patients that have a later onset, as you can see here, after about 2 years, a later onset, non-heavy alcohol use. When we look at 5-year survival of these patients are very similar. Of course, if we're talking about patients who have a severe alcohol use disorder, we should always maintain the patient should maintain abstinence. But when we look at the survival of the patients, what we see is that very light or non-heavy alcohol use in these patients is not necessarily, at least in 5-year term, associated with lower survival. So early alcohol use patterns were associated, particularly in patients, younger patients, patients who had multiple previous rehabilitation attempts, and patients that had probably, this reflects just more severe liver disease. What about predicting risk after transplantation? Well, this is probably the most well-known score. It's called the SALT score. It was generated, a model to predict sustained alcohol use after transplant. Here we used a cutoff. The cutoff use is 5. So patients with more than 5 had a C-statistic estimate of 0.76 to predict sustained alcohol use after the transplant. And here, the criteria used are: how heavy was the alcohol consumption? Were there prior failed rehabilitation? Any history of alcohol-related legal issues, driving and violence and whatnot, and also history of illicit substance use. Okay, so what do we do with these patients? How do we know if they drink? Because as we know, due to stigma, many patients do not self-report how much they drink or whether or not they drink. And something that has really, I wouldn't say revolutionized, but certainly has been a small game changer for us dealing with these patients is the presence of very sensitive markers with very low false positive rates of alcohol consumption. And here, I'd like to call your attention to the boxed out area, in particular to serum phosphatidylethanol, which has already been studied in the pre and post-transplant setting. We know it's very specific, it's easy to collect, just a blood withdrawal. It can detect longer periods than the other markers, but it's still expensive and still not widely available. What is phosphatidylethanol? It's a blood test, measures the level of phosphatidylethanol, which is a direct marker of alcohol consumption. And here, the presence of ethanol, phosphatidylcholine is converted to PET on red blood cell membrane by phospholipase D enzyme. And here, we have to consider some factors. If patients have severe anemia, this can influence the levels. And there are many other factors that we're not quite sure. Severity of liver disease or the presence of bariatric surgery, it's still not clear across the board if this is, in terms of quantity, really reliable, but certainly in terms of a detection test, it is quite reliable. The cutoffs that are used are here below. For moderate ethanol consumption, 20 to 200 nanograms, and for heavy, over 200. Okay, so we've used the markers before, after transplant, and we speak to our patients. How do we treat them? How do we treat alcohol use disorder? It's really challenging, particularly in the pre-transplant setting. As we know, patients who have decompensated severe liver disease can't receive a lot of types of drugs. There are, as you see here on the graph, in terms of pharmacotherapy, there are a few options, but as you see, most of them are off-label. So besides pharmacotherapy, there are some drugs we can use, or camprosate if patients don't have kidney disease, baclofen if patients don't have a severe encephalopathy or very severe jaundice. But we can certainly apply to all patients is behavioral treatment. And behavioral treatment can range, in most cases, to cognitive behavioral treatment, here through the help of psychiatrists and psychologists, helping patients create coping skills to recognize and restructure unhealthy thoughts and behavioral patterns. What I personally use very often is motivational enhancement, meaning we help addicted people to change their own thoughts and behaviors, and we always use positive reinforcement, meaning if I see a patient, the patient used to drink a bottle of vodka, now they're drinking one beer, I motivate them to keep things going. I don't scorn them for still drinking alcohol. And here, this is a very nice review, which I like call your attention to. How do we treat AUD in the setting of transplant? Here, I'm going to go very quickly. In the pre-transplant setting, if the patients are too ill for behavioral therapy, we still have to consider them as transplant candidates, but they need a psychosocial evaluation. If patients have more than one risk factor of relapse, they're young, previous histories, we definitely need to consider these are patients that we should consider pharmacotherapy besides behavioral therapy. And these are patients where we really need to do serial biomarker testing and, if necessary, also start therapy. In the post-transplant setting, the setting is not quite different. Okay. So, as a sort of take to work, I heard this term recently and I like it. What are the take to work messages that I can leave you? AOD is a rising indication for liver transplantation, and it's going to bring more and more challenges for us as transplant doctors. Early ALT is a viable option in selected patients with severe alcohol-related hepatitis. We don't know yet exactly how select and how to select these. And this requires really a multidisciplinary approach that assesses both clinical and also psychological suitability, and issues such as alcohol relapse and use of healthcare resources are at the forefront when we consider these patients with ALT. And I leave you here with a small reminder, in 3 weeks, we have a very exciting, also on the same topic, we have 2 special guests, and I encourage you on the 14th of December to participate online or in person to the symposium. Thank you very much for your attention.
Vielen Dank, Susanna, für diese sehr schöne Overview von diesem Problem. Gibt es Fragen für Susanna?
Susanna.
Ja, danke, Vanessa.
Ja, danke vielmals. Wir müssen kurz.
Vanessa?
Yeah. We had echo, that's why. Can you hear the echo or is it okay?
Ein bisschen, ja, ist gut.
Okay. Vielleicht noch ganz kurz, dass du etwas sagst zum Thema Relapse, oder? 10% tönt wahnsinnig viel, aber vielleicht kannst du ganz kurz für die zum Beispiel Hepatitis C Relapse nicht im Kopf haben, oder früher war das ja eigentlich 100% Relapse, bevor man die DAA hatte, oder? Also einfach, dass du da vielleicht ganz kurz noch hier etwas dazu sagen kannst in Relation, und dann noch ganz kurz, oder du hast gesagt, diesen Sustained Alcohol Score, diesen SALT, wir machen ja schon einen Unterschied, weil dort steht nur, wie viel Drinks pro Tag. Wir machen ja schon einen Unterschied, ob du quasi 2 Becher Wodka oder 20 Bier pro Tag trinkst, oder ist das weniger relevant? Vielleicht kannst du dazu noch etwas sagen.
Okay, bezüglich, was du gesagt hast, von 11 oder 12% harmful use. So, das ist relevant, also die sind 10%. Aber wie du gesagt hast, für 20 Jahren, es war 100% HCV-HCV. Und so hier, der Punkt ist, einfach muss man als Leberärztin, Chirurgin oder Medizin, muss man einfach diese Patienten finden und behandeln. Vor und nachher. Und das machen wir noch nicht egal. Ich glaube, hier und überall nicht ideal. Und wenn man spricht über sustained alcohol consumption oder harmful consumption, ist es normalerweise etwas, das passiert innerhalb der ersten Jahre Posttransplantation. Das ist erstmal etwas, das wir müssen unbedingt früh finden und versuchen, sagen wir, aggressiv zu behandeln, multidisziplinär mit unseren Kollegen von der Wissenschaft. Eine zweite Frage, Entschuldigung, kannst du mich erinnern?
Yeah, it's with the SALT score. It's not only the amount, but also what they drink.
Not really. Here, I would say it's really the amount of what they drink, because each patient has their patterns. I mean, there are patients who drink 20 beers a day, and there are patients who drink a quarter bottle of vodka, and in terms of alcohol, the quantity is the same. So it's more, I would say here we have the drinks, but it's more the drinks to quantify the amount of grams of alcohol that is needed for the patient to maintain, let's say, their alcohol addiction.